My name is Neville Hacker and I have been running the Gynaecological Cancer Centre at the Royal Hospital for Women in Sydney since 1986. One of my major objectives when I came back was to set up a multidisciplinary team. Over the next 3 or 4 years, I managed to get a lot of that team together, including Professor Michael Friedlander, who, along with myself, has been a past president of the IGCS.
I think what makes the Royal Hospital for Women different to other centres around the country, and in fact possibly many other places around the world, is the fact that we have a very collegial, cooperative group of people working together, specialising in the field of gynaecological oncology. We work very closely together for over a quarter of a century. There are multiple individuals, all who bring special levels of expertise, including surgery, medical oncology, palliative care, genetics, with expert nursing support.
We've always had a strong focus on the patient. We have a weekly meeting at which each inpatient is discussed by members of the multidisciplinary team. We have a lot of expertise in different areas within that team. They each bring a lot of passion to the discussion. This makes for a resolution of often very complex and challenging problems.
Radiation oncology is a very important part of a gynaecological oncology service. We use radiotherapy in many patients, sometimes after surgery, sometimes on its own as a definitive treatment, or in combination with chemotherapy. Some patients, in fact, have all 3 modalities of treatment. Most patients are treated with curative intent. Some, however, have more advanced disease, and radiotherapy can be a very useful part of their palliative management as well. One of the things that we do slightly differently here from many gynaecological oncology centres is we make more use of the combination of surgery and radiotherapy for stage 1B cervix cancer. Here we've had very good results using surgery for the larger stage 1Bs and then following that with small field radiotherapy rather than traditional large post-operative fields. As you can see here, on the left is the standard post-operative field covering the pelvic lymph nodes up to the level of L4-5. Patients had the pelvic lymph nodes removed and they were clear. There's really no need to treat that area. And so we now use a small central pelvic field with a lower upper level and narrower borders at the side. Most of the bowel is no longer in the field, but you're just covering the central region where you're most concerned about disease recurrence. And this is very well tolerated, both acutely and in the long term.
At the Royal Hospital for Women, we have 2 accredited training positions. We usually take 1 trainee from Australia or New Zealand who participates in our usual gynaecological training program over 3 years. We also make an effort to take an overseas person, particularly trainees from developing countries. The overseas trainees teach us to be very culturally diverse, and we benefit by having them teach us how they would manage cases overseas in a different environment. And they take back with them some of the surgical and clinical skills they otherwise would not have learnt.
We have been very much the cutting edge of research in gynaecological oncology in Australia at the Royal Hospital for Women. I was the founder and initial chair of the Australia-New Zealand Gynaecological Oncology Group. We've been running clinical trials here from the day I started. These are cutting-edge trials that really changed the way that we manage women with ovarian cancer specifically, but also other gynaecological cancer types. And at the moment we're focusing mainly in PARP inhibitors and in immune checkpoint inhibitors.
The most challenging cancer that we treat is ovarian cancer. It's challenging because it's so difficult to diagnose while still confined to the ovary. So for the last 20 years, we've had a basic research program aimed at trying to find a screening test that would allow population screening. This is really the holy grail of gynecological cancer research.
There is a strong culture for nursing research in the department, and this is very well supported by Professor Hacker and by nursing administration. Most recently, a part of my PhD research has been looking at the trends in incidence and mortality for vulvar cancer in Australia over the last 30 years. And overall we found that there's been an increasing incidence in vulvar cancer for women under 60 years of age, and this is probably most attributable to their exposure to the human papillomavirus since the 1950s. We are also looking at the presence of p53 mutations in squamous cell carcinoma of the vulva, and this immunohistochemical profile may be beneficial in determining disease progression and prognosis in the individual patient with vulvar cancer.
Women that have gynaecological cancer suffer a lot of side effects from their surgery and their treatments. A lot of that is anxiety and depression. These are the sorts of things that I deal with and help them with. And one of the biggest problems I find is fertility, because we do have very young women come in here as well who've got to have all their reproductive organs removed, and therefore they can't have children, and that often causes the most extraordinary grief. I think the uniqueness of this centre is that we are able to actually diagnose patients, treat patients, and take them right through to maybe palliative care. And we do all that under the same roof. And I feel quite privileged that I'm involved in that care, that long-term care.
One of our major interests has been in the surgical management of the stage 1B2 cervical cancer. Recently we had a young woman, Lisa, who elected not to have the surgery, although she had a very large 1B2 cervical cancer at about 18 to 19 weeks, pregnant. We got Michael Friedlander involved, and she had some chemotherapy and had a remarkably good response to the chemotherapy. And she subsequently had a successful caesarean radical hysterectomy, and the baby's doing very well.
The hospital staff were just outstanding, and we couldn't fault it, going from oncology to birthing suite, and you know, from the reception staff and the professors and every single person that I have ever met here and continue to meet and catch up with on the outside world. It's like another life. Like, I feel like royalty when I'm here, and I'm just so ever grateful that I stepped foot in this hospital. Yeah, I really am.